With 3 in 5 people who suffer a heart attack thought to have PAD, it only makes sense that patients with PAD and CAD, or coronary artery disease, could be treated in one place, whether it's a hospital or an ambulatory surgical center, or ASC. An ASC, simply put, is a healthcare facility that can be freestanding or be attached to a larger hospital facility, provides diagnostic and surgical procedures that don't require an overnight hospital stay. Some patients like ASCs because they typically offer shorter wait times, lower costs, and smaller chances of infectious disease exposure. ASCs are popping up across the country, starting to offer not only peripheral interventions for PAD, but also coronary interventions, or what we all know as heart catherizations, or heart caths. The demand for alternative sites of service by patients and providers really escalated as patients and physicians sought COVID-free environments, as you know, right, for urgent and elective coronary procedures that were delayed due to overburdened hospitals, increasing the risk of life-threatening coronary and peripheral events. Here to talk about research and evidence that supports this growing trend, as well as what you as a patient needs to know to make the decision as to where you get treated, are Dr. Sarang Mangalmurti, the second to perform a heart catheterization at an ASC in Pennsylvania, about 30 minutes from Philadelphia, and vascular surgeon Dr. Nilish Balar, who treats peripherals in both an OBL and ASC setting. Welcome to you both.
Thank you.
Thank you.
Well, I really want to start off, and I know I gave a brief example of what an ASC is, but how would you describe an ASC versus an OBL versus a hospital?
Yeah, so I guess I'll start. So the hospital, I think we're all familiar with. Obviously, it has a full range of facilities, not just for cardiovascular care, but also all of the allied facilities, other specialties, all the services, whether it's blood bank services, respiratory services, and so forth. Your ambulatory surgery center is going to have all of your capabilities to monitor patients during cardiac or vascular procedures. They'll have respiratory services. So if a patient, say, needs anesthesia, even general anesthesia, that can be performed in an ambulatory surgical center. And the cardiovascular monitoring that's required is also done at that time. And an office-based laboratory or office-based situation is more of an extension of the office. So procedures that are performed there are going to be your lowest risk procedures. And those are done as an extension of an office. So that would be procedures where the patient doesn't need a high level of sedation done. So you don't need to monitor that patient in terms of their heart rhythm or their EKG. You don't need certainly high levels of anesthesia. That's a lot of local anesthetic procedures. Those can be done in that setting. That's a general overview of the differences in those settings.
And Dr. Balar, what are some of the drawbacks and the benefits that you see with the OBLs and the ASCs for patients? First off, whether it's peripheral or a coronary intervention.
So just as described, there are regulations, and in terms of differences between ASC and OBL, ASC has strict guidelines and standards. It's a standardized place where Medicare and the state governs how it is built, what are the requirements, and conscious sedation is dependent on each state. Some state mandate that you have a certain standards. And compared to what we started in 2012, the safety and the requirements has progressed over years. And now most of the state has mandated a reporting system where within 24 hours, if you have an adverse outcome, it needs to be reported to the state so that they can modify and guide us in terms of upgrading the facility and other stuff. So over the years, I should say from 2012, when it started first, at least with the PAD, there have been several different modifications that they have done, and safety has been a priority in all those modifications. So I think the question remains that, is it safe for the patient, and what are the difference between ASC and OBL? So OBL, even though it is classified as extension of office, certain states, especially New York, New Jersey, would mandate you to have a license, especially in New Jersey. There's nothing as office extension. Every facility, even if they do minor procedure, needs to be registered with the state and should pass through a evaluation either with Quad A or JCO or whatever agencies you decide. So most of them are going to be safe, and most of the procedures that are done, the risk ratio, as you can see from multiple studies, is that the safety is definitely number one on the list, and complication rates are ranging from 0.5 to 1% at the most. And there's no difference between the complications that you may get in the hospital versus outpatient. And since PAD has evolved, access site complication is common for coronary as well as PAD. And those have always been very low in terms of access site. Highest reported is 1.5% that may require admission to the hospital for overnight observation or a hematoma. So that's where the difference and the risk and benefits for a patient lies.
And when you're talking about the access site, you're talking about the puncture point, whether it's radial access, meaning in your wrist, or whether it's through the groin, et cetera, right?
That is correct.
And so, the reason we're really kicking off our conference with this topic and making this our keynote discussion is because this is really a growing trend to see more legs and hearts treated in freestanding facilities, as I explained, especially in light of COVID and trying to get people treated sooner and more effectively so they don't end up with life-threatening complications with their heart or their legs due to lack of treatment or delayed treatment. And a key society known as SCI just came out with new guidelines just in the past few weeks for treating hearts using minimally invasive methods in ASCs. And I wanted to see if Dr. Mangalmurti could go through some of the key things that patients need to know about those brand new guidelines.
Sure, yeah. So, these guidelines have been sort of a work in progress for the last 20 years. If you were going to get a coronary stent, say 20 years ago, that stent would have to be done in the hospital. You'd have to have a surgical team that would have to be present in the hospital at the time of that stent placement. And you'd almost certainly have to stay overnight after that stent was put in the heart for observation, sometimes even an extra night. This is going back 20 years. And so there's really been two key questions that have been asked over the last 15 years in particular when it comes to stenting of the heart. The first question is, do you need a surgical team on site when you're doing a heart stent? And the second question is, do patients need to stay overnight if they get an uncomplicated stent put in, like what we call an elective stent? They come from home, they get a heart stent put in, can they go home the same day? And through a lot of research over the last 15 to 20 years, particularly last, I'd say 10 to 15 years, both of those questions have been answered. And the first question about whether you need surgery in the hospital at the same time that the stent is being put in, that question has virtually been put to bed. It basically has been answered. And the answer is no. You do not need surgery in the hospital. You do not need surgery on site. This has been looked at through hundreds of studies. Millions of patients have been looked at through various studies, randomized registries, and they have all virtually uniformly shown that the complication rates in hospitals where they don't have surgery in the hospital compared to hospitals that have surgery on site, as they call it, are the same. So whether you have surgery on site or you don't, it doesn't make a difference for the vast majority of cases and for the vast majority of patients. So that question has been answered. And what you see now are a lot of hospitals that can perform heart stenting without having surgery on site. I happen to practice at a hospital that is exactly like that, and I've been doing that for the last 10 years. The second question of whether you can send people home the same day has also been answered. And there have been several studies that have shown that as long as patients, if they're going to have problems, it's going to be early on within the first typically 4 to 5 hours after a stent is put in. As long as you watch them within that first few hours after their procedure, if they don't have any problems, they can safely go home. That question has also been looked at, and the studies have clearly shown that for elective patients coming from home, stable patients, they can be sent home the same day with minimal risk. Those two events have led to the guidelines which have come out that Kym had mentioned, which is that outpatient procedures, stenting of the heart, can be done in accordance with certain sort of guidelines to sort of look at what's considered safe, types of patients to choose, and so forth. So basically, what the societies are saying is, look, if you have a patient who doesn't have a complex disease, that is, they don't require a lot of extra complex tools to fix their vessels, it's something that's a straightforward stent to put in, and that patient is not a particularly complicated or risky patient to do, that patient can safely be done outside the hospital without having to worry about surgery, and that patient can safely be sent home the same day, which is what's involved when you do those patients in an ambulatory surgical center.
A study on insurance data, though, collected between 2007 and 2016, the results showed an increase in bleeding risk in ASCs versus hospitals. And the study expressed concern that ASCs may not always be staffed to manage problems like early hematoma formation that you had mentioned that could otherwise be observed overnight under outpatient status in a hospital. Have you encountered that in your facility, or has anyone expressed a concern about that with you? And how do you handle those situations?
Yeah, so, I would say one good thing about the ambulatory surgical center is that from a staffing standpoint, the patients tend to actually get more attention. So the ratio of staff members to patients tends to be higher in our ASC than it is in the hospital. Like I know when I do procedures in the hospital, in the recovery room, for example, I may have one nurse who's monitoring 4 post-catheterization patients, whereas in the ASC, I may have one nurse only monitoring 2 patients. So typically ASCs, you're going to get more attention just because the volume of patients is smaller in comparison to the hospital. The question, and I think the solution to some of the issues that you brought up, Kym, and those are legitimate issues that need to be dealt with, which is, complications after a procedure, it's really about the personnel that you staff your ASC with, right? So you need to make sure that the people that are working in the ASC are people who are qualified to be able to manage these patients afterward. And I think what you're going to see over the next 5 to 10 years and even longer is as more and more of these cardiac procedures are being done in the ASC setting, a lot of the staff that would normally be working in the hospital are going to start working in the ASC, right? Because a lot of that volume is going to start shifting out of the hospital into the ASC setting. So naturally, the hospital is not going to be able to keep all of those staff members on staff in the hospital, and those staff members want to work somewhere. They have a skill set that's useful, and they're going to be employed by the ASC. And my ASC, I staff members who all work either in the hospital that I work in or used to work in a hospital in the cath lab and now work at our ASC. So I haven't had that issue because of the staff that I use. I would also just say one other thing with cardiac procedures, vascular complication rates like Dr. Balar had mentioned about hematoma formation or bleeding at the site where you do the procedure is significantly lower for cardiac procedures, because more than 70% of cardiac procedures can be done from what's called the radial approach, which is access through the wrist artery, not through the groin. And the biggest benefit to accessing the wrist artery is a reduction of bleeding from the access site. And one good thing that's happened, again, over the last 15, 20 years, particularly the last 10 to 15 years, is that a lot of physicians have been trained on the techniques on accessing the wrist for their heart procedures.
For patients that are interviewing the doctors, let's say in an ASC and for their heart cath, but I would also argue even with peripheral interventions in an OBL or ASC, would you suggest a patient ask their doctor if they're using an intravascular ultrasound known as IVUS for additional precautions in terms of providing more imaging and for better sizing and placement of the balloons and stents during these procedures?
I'll answer that. IVUS definitely has changed some of the measurements that we do and long-term outcome. If you haven't measured or if you oversize or undersize the stent, you will have different outcome, as well as you will miss the lesion on plain 2D angiography with even multiple views. It's very hard to identify some of the lesions, especially below the knee, popliteal, or even in SFA at the adductor canal, or areas which are difficult to visualize just on the angiography. So IVUS is an additional tool, and I think it would be important. Apart from that, I think the patient should be asking is if they have access. First of all, the outpatient procedures are done in the office base, but does the physician have access to other place that if anything happens, is he going to be the one taking care of the patient, or are they just referred? Because if they are referred to a tertiary center, unless they have an agreement, some people tend to not accept those patients, and that delays the care. So it's very important for a patient to question the provider that what support system you have, what if this happens, and what are the risks that this happens usually.
I really want to drive that point home. That is a really important point, Dr. Balar, that when you're interviewing a doctor before any procedure, what are your hospital privileges and what is your plan A and plan B in case there is some sort of bleeding event or some other complication and you need to rush me to an emergency room? Are you going to be the one that's going to follow me in the ambulance, be there, get the care? Are you going to be able to converse with the doctors there and have privileges to help make sure and follow my treatment? Is that?
Yeah, I agree. And I think I think it's important for that to be the case with any procedure that's done in the ambulatory surgical center or an OBL. I think any of these facilities, vascular procedures, peripheral vascular procedures, which have been done for quite some time. I think now that we're seeing cardiac procedures enter into that ASC space, I think that's particularly important that the ASCs have a clear a plan in place for patients should they need to be transferred to a hospital for a tertiary care or more advanced care. Because while Dr. Balar had mentioned the numbers, the numbers are extremely low for complications that require urgent intervention in a hospital setting. We're talking about anywhere from 0.1% to maybe 0.4%. So that's a small number of patients who might need to, say, go to a hospital for some care, but it can still happen. And so there needs to be a formal plan, and one that I think patients are entitled to hear from their physician if they're going to get a procedure done. I know if I were a patient, I would want to know that, okay, if something happens, there is an actual plan in place, for me to be, quickly transferred to a hospital, and who will take care of me at that hospital. And, if the physician says, listen, I can't take care of you immediately because I need to do X, Y, Z, at least they have somebody else. My partner is there who will be able to take care of you. I mean, something has to be, it can't just be, we're going to drop you off somewhere and somebody will figure out something. That's not the way it has to be. There has to be a clear delineation of steps in taking care of the patient.
So what are some of the limitations for, and another term we use is percutaneous coronary interventions, that's pretty much heart caths. Just want to throw that out there for patients in case they hear PCI or something, in their travels. But of course, not all patients would be eligible to receive care or should receive care in an ASC due to their comorbidities and other risk factors. Can you go through some of those deciding factors so patients are able to make the determination themselves as to whether they should approach an ASC or they should have their interventions done in a hospital setting?
Yeah. So, the guidelines that were recently published, as you had alluded to, if you're looking for something in the literature to read, if that's what if you want something concrete on paper, I think that's a good resource to use, and I'm sure that Kym can give you a link to that article, which basically looks at the patient factors that would influence the decision between ASC versus hospital. But if you're not somebody who necessarily wants to read through a document or do that, I would say look at the important factors that you want to look at for your own heart would be, the biggest factor would be your, what we call left ventricular function. Okay, so that is how does your heart function, right? Because there are people who have normal heart function, what we call an ejection fraction that's normal, and those patients are going to do fine in an outpatient setting, in an ASC for an intervention. But if you're somebody who has a reduced heart function, that is, your ejection fraction is diminished, okay? And if you're a patient who has heart disease, it probably sounds more familiar what I'm talking about, but ejection fraction is oftentimes what a cardiologist who takes care of you will talk to you about and say, hey, listen, your ejection fraction is 50%, your ejection fraction is 25%. Nobody has 100%. It's 50% is considered normal. If your ejection fraction is low, that typically is one where it's not a good candidate for the ASC setting. That's typically a patient who should be done in a more hospital-based setting, because those patients tend to have less of a reserve should there be any issues in terms of their procedure. So that's probably the number one on the list, and physicians like myself typically look at that as the first criterion for whether a patient should be done in the hospital or in the ASC. The second thing that you'd look at would be, do you have any significant heart valve disease? So some patients have, for example, aortic stenosis. They have very, very severe aortic stenosis. That means a narrowing of one of their heart valves. or they may have a valve that's very, very leaky, what we call regurgitation, things like that. Again, if you're a heart patient, these may sound familiar to you, but those are patients, again, who, if you have very, very bad valve disease, you're at a higher risk for complications, or if you have complications, having trouble after a procedure, you might do better in an ASC setting. So those would be sort of heart-related issues. There are some types of blockages that people can have that are better treated in the hospital. For example, somebody may have what's called a left main blockage, which is the main trunk of one of their heart arteries. Typically, most operators will not treat that in a surgical center. They'll send that to the hospital and treat that there. But usually, most physicians have the correct judgment to not do that in an ASC setting. Now, there are some patients who have several medical issues that would be dangerous for an ASC setting. For example, if a patient is at a very high risk of bleeding, so there are some patients who might have some bleeding disorder or bleeding issues, they would not be appropriate for the ambulatory surgical center. They would be better done in a hospital where they have some resources available. And then there are some patients who, for example, they may have kidney dysfunction or issues, respiratory issues where, for example, they have terrible lungs. And even if you give them a little bit of what we call conscious sedation, there's a risk that they may have some respiratory issues. They should be done in the hospital setting. So I would say those are 4 or 5 things that generally are exclusions for an ASC procedure. And patients themselves can ask physicians about it if they're concerned. They might say, hey, is my heart strong enough for this procedure in an ASC? Are my lungs strong enough for this procedure? These are probably good questions to ask your physician if you're concerned about it.
That's fantastic. And Dr. Balar, do you have anything to add? Are there any patients, even with peripherals, where you would say, hey, you know what? I'm not going to treat you here in the ASC. We're going to a hospital setting. I know for some of our patients, if someone doesn't have anyone really in their life to care for them, they're all alone, I usually will say it's better in a hospital setting and get a later day appointment so that you do have an overnight stay to be watched versus being home alone overnight after a procedure. But what are your thoughts?
I totally agree. This involves so many factors apart from the medical risk. You just mentioned about the patient side of the story, and it should be a decision between what is the patient's social network that can support it, or the supporting network, versus the medical. And once you discuss both of them, then you should decide where would be the treatment that would most benefit the patient and have the best outcome. So in my view, I think it's a very personal decision where each factor should be considered before making a judgment of where you're going to do the procedure. It's possible that all the procedures could be done at either side. The comfort, as you can see from COVID, highlighted the importance of OBL's presence in the whole country, especially in New York area. At the time of COVID, we were the only places that any elective procedures, life-saving and limb-saving procedures could be performed. And those were horrible days. So even the high-risk patients had to be done in OBL, and they did very good. So it's such a personal choice and decisions which should be arrived after consulting with both the family, the patient, and the physician.
Now, there's also a little bit of an elephant in the room. Of late, there have been concerns expressed in the media by research reports, and even there's a DOJ, Department of Justice investigation into one set of facilities in regards to the overuse, the overtreatment at some outpatient centers, and they're being investigated for unnecessary or too early of interventions when it comes particularly to peripherals. How do we make sure that it doesn't happen with coronary interventions? How do patients know whether the procedure being offered to them is truly necessary? Are there protections in place for the patient?
That is a great question, and that is an important concern. So, in terms of coronary intervention, remember, there's no such thing as routine coronary angiograms or catheterizations, right? There has to be a good reason to take someone for a coronary procedure. Typically, it's going to be from some kind of new onset of symptoms, chest pain, shortness of breath, something that is suggesting that there is a coronary stenosis that needs to be investigated. And oftentimes there's preceding testing, stress testing, or something that suggests that there may be a coronary blockage that warrants this procedure. So if someone is doing a catheterization without symptoms and testing, and it seems like there's not enough preceding workup prior to that, I would be a little suspicious that not enough workup has been done to justify a procedure for the heart. And so that would be number one. As far as the risk of unnecessary stenting in the heart in the outpatient or the ASC or a setting, this issue actually had come up in the hospital setting about 12 years ago. There had been, coronary stenting had been overused in the hospital setting. There were some very high profile cases where there were cardiologists who had actually gone to jail for inappropriate stenting of blockages that were not significant, just because it was easy to do and for financial reasons and so forth. And that really changed a lot of the mindset and the guidelines and the principles of coronary stenting after that. So what happened is a lot of criteria came out for what was called appropriate use, and these were all mandated by the society. So coronary interventionalists like myself over the last 15 years have all been working under the appropriate guidelines for stenting, and it's sort of been embedded within us, which is the right thing. So nowadays there aren't really, like, we're all kind of used to sort of what's considered like how to evaluate a patient for what needs to be stented, the appropriate testing that needs to be done, and so forth. So I don't think there's a lot of cardiologists out there who are stenting things just based on what they see. They're oftentimes doing the appropriate testing for that. So I think as patients, you can be rest assured that this is a much different generation of cardiologists now than maybe there were in the past. And the last thing I would say about that is, coronary stenting is highly regulated. And what I mean by that is it's really watched by a lot of societies, by not just the cardiology societies, but state governments and even national registries. So, coronary stenting, there's a huge amount of research that's done, and there's actually large databases, national databases that pretty much monitor almost every single stent that's put in throughout the United States. There's what's called the NCDR Cath PCI registry. And what that is a registry that logs in every PCI that's done. That's a heart stent that's done throughout the country. Now that's done through the hospitals, because 99% of the coronary stents are done through the hospital, right? But as the ASCs start to do more and more of these PCIs, the societies and the governments don't want to lose this database, because this is where we get our information from. And so it's not going to be very difficult for them to start abstracting that information from the ASCs. And once they start doing that, then it's going to be very difficult for a cardiologist, even if they wanted to say do the inappropriate thing, for them to be able to do so, because all of that information is going to be put into the registry. It's going to be examined, and it's going to be available for people to look at. And so I don't think we're going to see that same issue in the coronary world.
Yeah, and Dr. Balar, why don't we have that, or do we have that for peripherals, or is that something that is forming? Because ProPublica came out with an article talking about one particular company and a hospital system in Wichita, Kansas, where the doctor was caught putting in so many balloons, so many stents, and they're investigating that at this point. As a patient, I mean, personally, when it came to my dad with coronary and with some of the patients that I work with, I really encourage them to get the, CT angiogram with contrast ahead of time for coronaries, the 256 slice CT scan. And then you sit down with the doctor and you say, okay, what's your plan A? What's your plan B? What's your plan C? With my dad, they were planning to do 5 stents. And I said, whoa, wait a minute. How many is actually necessary for right now? And then he ended up with 1. The doctor actually called me during the procedure and he was like, well, here's what I see. And I said, yeah, 1 stent, right? And he said, yeah, well, just 1 stent. But are we seeing with peripherals as well? I know I kind of rambled on there, Dr. Balar.
Yeah. So the peripheral is a very different entity when it comes to our collective database as well as the science. There are 2 sides of the story. So I think the ideally, it's such a large topic where peripheral arterial disease can start from claudication all the way to gangrene. When it's gangrene, the indications are very simple that it needs to be fixed. When it comes to claudication, that's where the water is pretty much muddied. And in terms of the large vessel size and much extensive network of peripheral artery, it is very hard to have the same data that we have for coronary. So you will get few incident reports. And recently there has been a trend, and just like you mentioned, they pull out the database from Medicare guidelines. But when they publish that they have done unnecessary stenting, they do not publish. None of the papers that I have reviewed has any premises where they say what was the indication for the procedure. There have been accusations that most of the physicians would do certain things because of the financial incentives. If you compare the financial incentives on either side, hospitals have more incentives than outpatient and ASCs when it comes to all that work and the money that is being wasted. So as long as the patients are educated and they know what they want, because a claudication, some patients, you can tell them that, listen, it's not that you're going to lose your leg, it's a lifestyle restriction. Whether you want to go for a stent, because once a stent is placed, it's very likely, we know that almost about in 2-3 years, there will be restenosis, even if we use the advanced technology with drug-eluting stents or drug-eluting balloons. And some patients continue to smoke. Some patients have different pathology, and they may come back. So I don't know how I would address other than individually deciding which patient was overtreated or which patient was undertreated. Because you might be undertreating some patients and you might be overtreating because we don't have a fixed science in all the peripheral arterial disease. It's evolving. We would have registry. We do try to monitor, and the state has been after that, where they want to know each re-interventions or complications that occurs because of multiple interventions. So the science is coming up, but till then, I would advise that the patients do ask the questions, sit down and discuss what would be the benefits, but what would be the downside if the things are not going well. So it's unlike cancer, as I would say. You don't do preemptive stenting thinking that there is disease. It's a very different pathology. You can wait it out and do the procedures, because once the procedure is done, it's like a time clock. At some point, it's going to fail, which would require re-intervention, either with angiogram or even much bigger surgery. So it's a very difficult question upfront to ask, but individual patients should sit down with the provider and go over all the risk and benefits and then make a decision.
Right. It's not just about, hey, I trust you. We're just going to go in and do an angiogram, sit down, have that productive conversation, and have them show you exactly their plan A, plan B. What are the tools? What are the techniques you're going to use? What are the complications you expect to run into? Very important questions. Frank really quickly has a question. We have about a minute left. So Frank, go ahead, ask the question.
Hi, thank you. Hello from Chicago. On behalf of the lay people in the audience, I wanted to find out or clarify if the ambulatory centers we're discussing are different from these minute clinics or walk-in places that are popping up throughout cities and towns that may lend to confusion as to where to go for particular treatments. Kym?
Yeah. The minute clinics, those are primarily, sort of small triage clinics that if somebody has a medical problem that they want to get a quick assessment of, they go and they basically triage to see if it's something small that they can take care of, or if it's something more significant that they need to then go to an emergency room for a higher level of care. Ambulatory surgical centers are not equipped or designed to diagnose disease, on the fly, if you will, the way these clinics are. These are centers that are open for a set number of hours, Monday through Friday or Monday through Saturday, and these are purely designed to do procedures. In fact, that's what they're there for. They're there for doing procedures that were set up specifically for that purpose, that were planned to be done. So they're not even there for emergency procedures. Someone for that week, there are X number of procedures that are scheduled, and those are the ones that are performed. There's an opening time and a closing time, and that's why all those patients go home. Nobody stays overnight in the ambulatory surgery center. And if somebody has a problem, let's say overnight, if they call the surgical center, it'll be closed. There'll be an on-call number, and that's typically at the physician's office or something like that. But those two entities are totally different from each other.
Thank you so much, Dr. Mangalmurti and Dr. Balar, for joining us in our opening keynote session. We really appreciate you. In 15 seconds, 30 seconds, can you each give us the final takeaways about the benefits, the drawbacks, why you would go to an ASC versus not for coronary interventions or peripheral? We'll start with Mangalmurti.
Yeah, the biggest benefit, I think, is for the patient experience, which is that the patients are going to get a higher level of closer, detailed attention. They're going to have a smoother procedure in terms of pre and post care. They're going to have a lower risk of infection since they're not actually being in the hospital setting and having to go into the hospital afterward. And they're in the end, their procedure is going to just be a lot smoother. They're not less likely to be canceled for emergencies. So it's going to end up being go off on more on time. And I think the patient experience, and from what we've seen, and my experience has been that the patients have a much better experience in the ASC than they do in the hospital.
Dr. Balar?
I agree totally. And it's more personalized care where you see and the staff, the people, and the level of comfort. There's no bureaucratic. If you go to a large institution, it's almost scary to figure out where you need to go to get your procedure done. If you see, there are almost about 15 to 20 people that sees you before you get your procedure done at the hospital, starting from the entry to the point where you reach the OR. Here, it would be like 2 or 3 people before you are in the operating room. So it's such a different experience. There's not that scary feeling that where am I? When I see all these big buildings, starting from parking all the way in there, it's multiple barriers. So all my patients literally tell me if I can do it in office, they do not want to go to the hospital.
Thank you so much, Dr. Balar and Dr. Mangalmurti. We really appreciate your time and volunteering to be here to educate all of us today.